the liver, from a histological point of view, is built up of so many small units that are hexagonal in shape, so they see it, and they are formed, but these small units even, they are formed by six structures. فشكلها سداسي وتتكون من six structures. Okay? And we call these small units which build up the liver as the hepatic lobules. Okay? Hepatic lobules. And we agreed that each hepatic lobule is consisted of portal triad at the periphery, which containing branches from the portal vein, hepatic artery, and bile duct. And in the center of each of these lobules, there is a central vein. So two things, portal triad and central vein. In between them now, there are very large blood capillaries. And when the blood capillary becomes very large, we call it sinusoid, like a sinus. Okay? So these are three structures now. And the major constituent now of this hepatic lobule, 80% made of liver cells. These liver cells arrange themselves in 1 to 2 rows. Each of these 2 rows now, we would call it a hepatic lamina or a hepatic plate. The same. Okay? So hepatic laminae, okay? Okay? The hepatic laminae or hepatic plates. 4 structures. The fifth thing you see is bile canaliculi, small canals that collect the bile produced by these hepatocytes and send it where? To the bile duct in the portal triad at the periphery. And the last thing we said, there is what? Small, or not small, large macrophages within the sinusoids that carry the function of filtration of the blood, and we call them Kupffer cells, referring to a scientist, German scientist named Karl Kupffer. So we have 6 structures now to build up structurally of the liver. However, the story becomes more interesting when the physiologists start studying now the liver. Because you know, this is just before we move, this is a view for the portal triad. You see that always in the portal triad, the largest structure is the portal vein. The middle-sized structure is hepatic artery. What are these within the hepatic artery? RBCs. And the smallest structure is the bile duct. So, when the physiologists start to study the liver, you know, they look to the liver from a functional point of view, because they are physiologists, not anatomists. So they said that within the liver, we have 2 main functions. The first function is the filtration of the blood. Yes? As the blood passes from the portal veins down into the sinusoids and end up where? In the central vein. So in this case, as the blood goes from the portal vein, from the periphery, down into the central vein, this we would call it, as a functional unit, okay, we would call it the hepatic lobule. So we would agree with anatomists on this, and we would call it the hepatic lobule. But to distinguish it from the hepatic lobule of the anatomists, we would call it the classical lobule. And you know, the classical always means old. Okay? So this is the classical, traditional description of a lobule. The classical lobule of the liver now is the first to be defined because it was actually defined by anatomists based on its structural unit, not functional, okay, unit. And it describes the blood flow from the periphery, from the portal veins into the central vein, okay? And it's concerned with which function of the liver? The classical lobule, from a physiological point of view, with filtration of the blood. Then the physiologists say that there is another function, which is production of bile. So for production of bile, you know that it goes in an inverted direction. So as the bile canaliculi produce the bile, it will go from the central vein toward where? The bile duct in the triad. Here, okay? So the physiologists decide that to describe another lobule for the bile production this time. And they say that the center of this lobule, since it's concerned with the bile production and secretion, it should be the bile duct within the triad. So they took the portal triad as the center for this lobule, and they join what? The adjacent central veins, 3 adjacent central veins together with imaginary lines. Okay? And they said, now this can describe the process of bile production, because all bile canaliculi here will drain into this duct, the same here and the same here. Okay? While the bile canaliculi here will drain where? Into this bile duct. Okay? So they start to divide the liver imaginary, not structurally, okay, into triangular structures. And the center of each triangle was the bile duct within the portal triad. Okay? So this now, the physiologists call it the portal lobule. Why they call it the portal lobule? Because its center is the portal triad. So now when we speak about the functional unit of the liver, we have a classical lobule describing the function of a blood filtration, which is equal to the hepatic lobule, the structural unit. But when we speak about the bile production, we have the portal lobule. Okay? The portal lobule describes what? The bile production and secretion. Okay? And it is center always is the bile duct within the portal triad. So it's a triangular area whose center is the portal triad and the periphery is imaginary lines connecting three surrounding portal veins. So if I take this bile duct and I draw a line here, this will be another imaginary portal lobule. You see what I said? Imaginary. This is also here. This will be another one. Okay? Things get more interesting now because after the physiologists, the pharmacologists get into the line now and they start studying what? There's an important function also in the liver, which is drug metabolism and detoxification. Okay? So they start to look to the liver from their own point of view as what? As related to which we call it what? Blood detoxification and metabolism. You know that the drugs in the blood get inside the venous circulation and they enter into the liver through the portal veins usually. And within the portal veins and hepatic arteries, of course. And as they go there, they start moving from the periphery towards the central vein. The same blood circulation. Whether the drug in the hepatic artery or it is in the portal vein, it has to pass from the periphery to the center. As the drugs pass, they will start to what? To be destroyed or metabolized. Okay? And toxins get into these hepatocytes. Okay? The hepatocytes now, they study, the pharmacologists study the ability of hepatocytes, okay, to detoxify drugs. And they discover that this ability is related to a very important thing, the survival of these cells and their ability to withstand the toxins to continue metabolism of the drugs, related to a very important thing, which is oxygenation of the cell. Okay, how much oxygen reach the cell, how much O2 reach to the cell, it can provide here with what? With more energy, it can provide here with more ability to survive and what? A better function of drug metabolism. Okay, so what they did, they looked at the blood supply, oxygenation. Okay, blood supply from where? Then from the hepatic artery, not the portal vein. Okay, they start to look how blood supply or oxygenated blood distributed within the liver between these classical hepatic lobules. They found that there are very interesting things. There are very small arterioles. Arterioles. When the artery is very wide, large, we call it a trunk. When it's very small, we would call it arteriole. So there are very small arteries. We call them arterioles. We call them distributing arterioles. If you look here, this is a classical hepatic lobule, as you see, central vein, portal triad. You will see a small artery passing from one hepatic artery to another hepatic artery between two adjacent portal triads. This now we would call it the hepatic or the distributing arteriole. Why we would call it distributing arteriole? Here it is, you see. This is one, this is from the other side, and they join. Those, all of these are which we call them distributing arterioles. Okay? As the distributing arterioles branched, okay, or outstretched from the hepatic artery toward the other arteriole from the adjacent hepatic artery, okay, they will start send the blood to two adjacent lobules, towards here and towards here. So in this case, as you see, the blood will start going from the periphery here towards the central vein, and the same from here. So if you want to imagine how is distribution of blood in each distributing arterioles, okay, between two hepatic arteries, you will draw a, which we call it diamond shape structure, okay. This diamond shape structure can explain how blood comes from the distributing arterioles down into the central veins within two adjacent classical lobules, okay. So what they did, they draw an imaginary, as you see here, an imaginary lobule related to the oxygenation of the cells. It's diamond in shape, and they call it the hepatic acinus or the portal acinus. Why the word acinus exactly? Do you remember I told you in the previous lecture? Acinus means very shape, okay? Because when you look to this lobule, it's diamond in shape. It's more or less shaped like acinus. It's actually not very sharp angles here. If you look carefully, it should become what? More rounded, okay? Like this. So it's more or less resembling an acinus. That's why they call it the hepatic acinus. So pharmacologists and pharmacists, they start calling this lobule or this structure as the hepatic acinus or the portal acinus, where its center now is what? Distributing arterioles, okay? One distributing arteriole would come from this hepatic artery, the other from this, and they will join in the middle, anastomose. So these are the distributing arterioles. What are distributing arterioles? Those are out-branching small arteries from the hepatic arteries, okay? That join, if you want a scientific definition, out-branching small arteries joining two hepatic arteries within adjacent portal triads, okay? So these are out-branching small arteries that anastomose or join two hepatic arteries within adjacent portal triads, okay? So a distributing arteriole, or if it is very difficult for you to know, you just can say an imaginary line that connects what? Two portal triads, which is the pathway for these arterioles. So you could say an imaginary line between these two portal triads, and I can draw here a diamond shape, more or less structure. This is one. If I took those two, it will be like this, okay? So this now will be called the hepatic acinus, okay? So in the hepatic acinus, if you look carefully, this, you see this line here? This is a hepatic acinus. It's related to the function of oxygenation of the hepatocytes, okay? It's related to the oxygenation of hepatocytes. And if you look, its periphery, its center is the distributing arterioles, okay? And its peripheries would be two triads and two central veins, okay? This would be called the hepatic acinus. As the blood now distributed towards the central vein, they start to see that the cells that are more close to the central veins, they will start to degenerate first. And they start to continue like this until they reach the periphery, closer to the distributing arteriole. Why? Because the most adjacent area to the arterioles here is the most oxygenated area. And as the blood moves, it starts to lose oxygen and gain CO2, okay? And move more and more until it reaches where? To the central vein, okay? So that's why they decided to divide the hepatic acinus now, okay, into three zones. A zone that contains very rich oxygen, okay, and the cells survive for longer time, okay, and they call it periportal, around the portal triads here. You see it? So what they call it? Zone 1, periportal, okay. So this is zone 1 or periportal, which is very rich what? In oxygen. The second area is here at the periphery, near the central vein, which is the poorest with oxygenation, and the cells degenerate first. So they call it pericentral or centrilobular area, because it's very close to what? To the central vein, okay? Because it's very close. So zone 3 now. Zone 3, the centrilobular area, which contains the least amount of oxygenation. So it's more sensitive to what? To ischemic injuries. So cells always degenerates around the central veins first, and They move on until they reach the portal triads. And the middle area in between, zone 2, what they call it? Mid-lobular, because it's in the middle of the hepatic lobule, or hepatic acinus, to be more precise. Okay? But just remember, all of this is imaginary. Okay? The only real structural thing there is the hepatic lobule. Okay? The classical, yes. The classical. So, this is now the term which we refer to it as hepatic acinus. Hepatic acinus is the lobule in the liver that concerned with oxygenation to the hepatocytes. It's divided into 3 zones. Zone 1, very rich in O2, we call it periportal. Zone 2, which is mid-side or mid-region, we call it mid-lobular. And zone 3, the centrilobular area, which is very poor blood or oxygen supply, let's say. Very poor in oxygen supply. Okay. Something else. When we spoke about the hepatic sinusoids, I said they are very large blood capillaries. And you know that from the HLS system, a blood capillary, okay, is made of endothelial cells. Right? So these are blood capillaries, but very large. So they should be lined with what? With endothelium. Okay? So they should be lined with endothelium. So if you look to the wall of these sinusoids, actually, this is an image. You can see a very flat cell here. This is the nucleus for a flat cell. If you look here, you see these blue cells? These are flat cells lining the wall of the sinusoids. These are the endothelial cells of the blood capillaries. Okay? And you see that they are usually continuous with the endothelium of the vein, as you see here. So in the liver now, these endothelial cells, the blue ones that line the sinusoids, we would call it to specialize it or to differentiate them from other endothelial cells with the name sinusoidal lining cells. So what is the sinusoidal lining cells or Ashan cells? These blue ones, these are nothing more than the endothelium of the capillaries, of the sinusoids. Okay? We call it sinusoidal lining cells. And you know that within the endothelium of the blood capillaries there are gaps. Yes? To allow for exchange of the products. Okay? So they have gaps between them. Okay? The gap between each sinusoidal lining cell and the other is about 0.5 micrometer. So any molecule less than 0.5 micrometer can easily get out from the blood into the hepatocytes and come back from hepatocytes into the sinusoids. Okay? Less than 0.5 micrometer. So these are the sinusoidal lining cells. Now, interesting thing, an anatomist and histologist, okay? This is an electron microscope transmission. You see these lining cells? This is in the sinusoid, this is hepatocyte with many microvilli, and these are the lining cells. Okay? And you see a very large cell here, very close to the sinusoidal lining cell. This is Kupffer cell. Okay? And you see here now, look, very interesting. Between the endothelial lining or the sinusoidal lining cells and the hepatocytes, there is a space, a very tiny space. Okay? Subsinusoidal or very sinusoidal space. Okay, which we call it now the space of Dizzy. Okay, this is space of Dizzy. Now, Dizzy, Joseph Dizzy, okay, was an anatomist and histologist. Father Joseph Dizzy was the assistant of a very famous physician and anatomist, اسمه Henrik von Waldeyer. سمعتوا فيه؟ اللي اكتشف الفالداير ستورز. Waldeyer was a very tough teacher and boss. كان قاسي جدا على Joseph. So he was getting Joseph to teach all the practical sessions, okay, with the Dr. Raed. He was asking him to do the dissections for him, يعمل كل الدissection. He was asking him to review and write his articles and research papers. فكان عامل له زي slave driving مثل ما بيحكوا، مستعد. فالداير كان قاسي جدا على ديزي. فلما ديزي خلص من حكم فالداير, he get graduated or get promoted, okay, لأنه كان فارغ وبعدين اشتغل assistant عنده. Once he was alone, he hated anatomy because of too much, so he changed into the field of histology. start studying what histology rather than anatomy. Okay? And during his study of the liver histology, he discovered a very small tiny space here between the sinusoidal lining cells and the hepatocytes. This space was very interesting at his time, and he called it space of Dizzy. Okay? And now he becomes famous. فمجهود فالداير كان كويس كثير عليه، لأنه خلاه يغير الفكر ويكتشف شيء خلد اسمه in the space of Dizzy. So that's how the story of the space of Dizzy came. Later on, when they started studying this space, they found that, as you see, within the space of Dizzy, there are so many microvilli of hepatocytes, branching, small villi, villas عارفين, finger-like projection, micro because they are micrometers in size. Why are these there? To increase the surface area. شو بفيد أزيد the surface area of hepatocyte more? لأنه the exchange of material between the plasma. شوفوا شو فايدة السبيس of Dizzy؟ لأنه very small وهاي sinusoidal lines. شوفوا ال RBCs. These plaques are RBCs. Now the RBCs and the blood cells cannot come in close contact with hepatocytes. The only thing that can pass into the space of Dizzy is the blood plasma. والبلازما هي اللي بتحتوي النيوتريانس أو التوكسينز اللي بدها. So in order to facilitate the exchange of products between the hepatocytes and the plasma, now the hepatocytes start making these microvilli to increase the surface area. So more exchange, okay, improving the function. So that's why space of Dizzy is very rich in microvilli, okay. Also, as they started studying the space of Dizzy under electron microscopes, they بتشوفوا هون هاي الهيباتوسايت، تشوفوا كلها هاي microvilli من الهيباتوسايت. High sinusoidal lining cell اللي هي الانdothelium, RBCs within the sinusoid. واضح, okay? And this is the space of Dizzy. وانتم ماشيين تشوفوا في خلايا. This is a cell and this is its nucleus. Can you see? They discovered that there are some cells, very small cells, in the space of Dizzy. What's the story of these cells? A Japanese scientist first discovered them and he called them by his name, Ito cells. So Ito is a name for a Japanese, okay, scientist. So Ito called these cells as what? Ito cells. And later on they discovered that they are carrying the function of storing fats. يخزنوا fat. And within the fat there are fat-soluble vitamins. The most important is vitamin A. So within the liver, this is the storage for vitamin A in your body. Within Ito cells, okay, in the space of Dizzy. So these are the Ito cells. And in recent years, they discovered that these Ito cells are very important in very important pathological condition. Liver cirrhosis, yes. Liver cirrhosis. Because when you have an injury, okay, in the sinusoid or in the hepatocyte, that will trigger these cells, بحفزها to what? To differentiate into another kind of cells. We would call it now myofibroblast. And these myofibroblasts, اللي هم بالأساس كانوا Ito cells, يخزنوا الفات, they started producing collagen fibers. Collagen type إيش؟ شوفي بالليفر. The framework of the liver is supported by reticular fibers. Collagen type 3. Yes. So they start to build up collagen type 3, okay, or reticular fibers. لما يبدوا the reticular fibers too many here, they will start to block the space of Dizzy. Okay? And the fibers can even go out into the sinusoids then, okay, and start destroying the structure of sinusoids. This will lead to what now? To interference with what? With blood flow through the sinusoid, from the triad into the central vein. Okay? And in that case, we will say we have a liver cirrhosis. And the liver cirrhosis will lead to something called portal hypertension. Then the blood will start to accumulate in the portal vein because of blockage of the sinusoid. Because it's blocked by what? By reticular fibers, okay? Produced by Ito cells. Some cells also located in the space of Dizzy are the natural killer cells, okay? Beta cells. What is it? Collagen type 3. This is the story of liver cirrhosis. Now the domains, you know that hepatocytes has a hepatocyte has two domains or two walls, let's say. Okay, one is adjacent to another hepatocyte. We would call it the lateral domain, and one is facing the space of dizzy. We would call it the sinusoidal domain because it's going toward the sinusoid. Okay, that's the only thing about it. In the sinusoidal domain, they have very rich what? Microvilli. These are evaginations. In the lateral domain between hepatocyte and hepatocyte في عندهم ايش؟ invagination بصير بدل ما في ارتفاع بصير ايش؟ منخفض. Invagination here and invagination from the other one, you will have the bile canalicula. Okay? So in the lateral domains you have bile canalicula. Okay? This is you can study it in let's move to the last thing. Since we spoke about the liver and the portal hypertension, it's worth to speak a little bit about the portal circulation. When we speak about the portal circulation, you know that في عنا the blood supply to the abdominal cavity. We have abdominal aorta. Abdominal aorta بيعطي branches posterior بتلف على طول الابdominal wall بسميهم ايش؟ lumbar arteries. بيعطي lateral branches ثلاث. It's the rule of three. Abdominal aorta follow the rule of three. You know that already من cardiovascular. Three lateral, suprarenal, renal, وgonadal. صح؟ The three terminations, common iliac, median sacral, and three anterior. The gut. The three anterior to the gut اللي هم celiac, superior mesenteric, وinferior mesenteric. ف3 anterior, 3 lateral, 3 terminations. Okay? هذول هم اللي بيهموني. 3 terminations بينزلوا على البلبس وعلى اللور لمب. The 3 laterals للretroperitoneal organs, primary retroperitoneals, suprarenal, renal, okay? وبيروحوا على الجونيتس. وفي 3 anterior للgut. هذول هم اللي بيهموني. The 3 anterior of the gut لأن الvenous circulation the same except in the 3 anterior. Okay? ما في celiac vein وسوبيريور وفيرال يرجعوا على الاي في سي، لا بيروحوا بيجمعوا حالهم وبيكونوا circulation خاصة فيهم تروح على الليفر. ليش؟ عشان filtration. For filtration of the blood. Good. Okay? So here you will have something different. In the portal circulation, we mean that the branches from the celiac, the superior mesenteric and the inferior mesenteric will join to form a large vein called portal vein that drains where? Into the liver. The portal vein بتكون عادة behind the neck of the pancreas. If you cut the pancreas, behind its neck you will see the portal vein. It's formed by a very two large veins. واحد جاي من the right side, the superior mesenteric vein, which is draining blood from the midgut. حكينا من lower part of the duodenum لوين؟
Anterior 2/3.
Yes, with an approximate 2/3 of transverse colon. لغاية 2/3 of transverse colon. هذا السوبيريور ميسنتريك. الثاني اللي هو السبلينيك. ليش؟ لأنه السبلينيك اللي بيقطع الميد لاين من الليفت للرايت. الانفيريور ميسنتريك cannot cross the midline, so instead it drains into the سبلينيك. الانفيريور ميسنتريك في الليفت بصب في السبلينيك، والسبلينيك بيروح join السوبيريور ميسنتريك behind the neck of the pancreas to form the portal vein. لما يتكون البورتال فين بيطلع من behind the duodenum وهون بيدخل في الهيباتوديودينال ليجامنت وبيروح للليفر. Okay? Very important point, clinical point of view. بما انه بيتكون behind the neck of the pancreas. النيك of pancreas على which vertebral level؟ neck of pancreas على level of transpyloric plane. إذا سمعتوا فيه. The transpyloric plane is at the level of L1. Okay? So you now على transpyloric you can add a sixth structure. حكينا على transpyloric في 5 structures. شو السادس راح يكون؟ The start or the formation of the initiation of portal vein. Okay? And it goes and drain where inside into the liver. Okay? فالبورتال vein هو بشكل أساسي the blood comes from the 3 anterior visceral branches, celiac, superior, inferior, mesenterics, okay, of the aorta, celiac, superior and inferior is retained by the portal vein, okay. This is very important. But when you look to the tributaries of the portal vein, أول واحد splenic, okay, superior mesenteric. شوفوا من وين؟ From the lower part of the duodenum to the 2/3 transverse colon اللي هي الميد gut. Inferior mesenteric من الديستال tail للانال canal upper 2/3. لأنه الأبر 2/3 of anal canal هم جزء الهايند جت. اللور ثيرد بيجي من حكيت لكم المحاضرة الماضية بروكتوديا. And once they join they form the pectinate line or rectoanal junction. Okay? And some other like right to left gastric, right gastroepigloic, and cystic vein. والleft gastroepigloic وين بيصب بالسبلينيك. Okay? And returns with the sibling. Okay? Into the portal circulation. So you see that هذا كله superior mesenteric. هذا كله ايش؟ الانفيريور mesenteric. It drains into the sibling, then the sibling join the superior mesenteric and they go into the portal vein. طبعا because of the streaming, angulation of joining allows for streaming of blood flow. يعني انه المixation بين the blood coming from the sibling or from the sibling don't mix that much. So most of the blood coming from the sibling will still in where in the left side of the portal vein and go to the left portal lobule, okay, or to the left portal lobe. The superior mesenteric they will still wear most of the blood in the right side and they go to the right hepatic lobe. Okay, clear? This helps us if there is what a malignancy in the gut. The malignancy لما يصير في tumor. Secondary metastasis, when it's going to metastasize into the liver, we can know now, expect, if it is in the cecum, for example, it will go with the superior mesenteric to the right lobe of the liver. However, if it is in the rectum, it will be metastasizing into the left lobe of the liver. So this could help you to distinguish the areas or the locations for metastasis. Okay? Portocaval anastomosis اللي بيصير انه بتعرفوا هاي الفينز السوبيريور mesenteric والانفيريور mesenteric draining the gut, they are draining the contents of the abdomen, صح؟ abdominal cavity into where the portal circulation. بس بتتذكروا حكيت لكم في الابدومينال وول بالاول في lumbar arteries من الايورتا وفي lumbar veins بتصب وين؟ في الاي في سي. فالابدومينال وول اذا ذاكرينه الفاشا والمسلز اوكي كلها هاي البلد الفينس درينج تاعها لوين بيروح؟ للسيستميك سيركوليشن للكيفال سيركوليشن يعني للفينا كيفا صح؟ اما الفينز في الابدومينال كافيتي to the portal. الان at the border of the internal surface of the abdominal wall where the abdominal contents join with the abdominal wall the veins there will anastomose. على حدود الابدومينال كافيتي you will have anastomosis where the blood there can either drain into the veins of the wall into the inferior vena cava or into the veins of the gut into the portal circulation. Okay? فالدم اللي على الانترنال سيرفيس هناك امامه خيارين either filtrated in capillaries to the veins of the caval circulation or to the portal circulation. These areas which we call it what? The portocaval anastomosis. The anastomosis between portal and caval veins. Okay? Portocaval anastomosis. Porto from portal, caval from the cava. Inferior vena cava. Okay? Anastomosis. So these anastomoses should be at the borders either. تكونش في نص الابدومينال كافيتي مستحيل. The areas and they go where to the left portal branch. Okay? These veins we usually refer to them as وينها؟ para-umbilical veins. Around the umbilicus. بس the outer surface of the abdominal wall cumbers وscarpus fascia they drain ايش؟ superficial epigastric إذا سمعتوا فيه. Okay? The superficial epigastric vein which will go into external iliac وبرجع مع الكيفال anastomos circulation. Okay? So this is another one عند الامبليكس. فصار في بالروف عند الاسوفيجاس لما بدخل على الابدومينال كافيتي. صار في بالفلور لما الريكتم بينتهي. اوكي؟ الانال كانال. صار في anteriorly عند الامبليكس. وين تتوقعوا وراه كمان؟ Behind in the posterior abdominal wall. Behind the ascending and descending colon. Why? Because the ascending and descending colons are retroperitoneal, not intra like the transverse. فهم نايمات مباشرة وين؟ نايمات على posterior abdominal wall. Okay? On the fascia of the muscles on the posterior abdominal wall, they are retroperitoneal there. Where they are sitting there, they form a gutter. Gutter is like a tunnel, مثل هذا الممر. We call it a gutter. This is which we call it the baracolic gutters. Baracolic gutters, the gutters around the ascending and descending colon, okay? Or baracolic grooves, if it's difficult to know that, what's the word gutter, okay? So we have two areas where the ascending and descending colon retroperitoneally in touch with the posterior abdominal wall. So now the blood there can either drain through the colic veins of the ascending colon. وين بيروحوا؟ بيروحوا للرايت colic vein للسوبيريور mesenteric، أو بجهة الديسندنج للليفت colic vein للinferior mesenteric. In both cases they will go to the border. The other option for blood there is to go where? Into the abdominal wall, lumbar veins, directly where? To the IVC, to the inferior vena cava. Okay? But those are the four areas of portocaval anastomosis. You can study them by yourself, but notice that one in the roof, one in the floor, one anterior, one posterior. In the roof, it is the esophageal veins, either draining into azygos or left gastric. In the floor, the rectal veins, superior rectal to the inferior mesenteric, middle and inferior to the internal area. Anteriorly in the umbilicus,
para-umbilical veins.
yes, the para-umbilical veins directly to the portal branch left or superficial epigastric vein behind the baracolic gutters, either through colic veins or through lumbar veins directly. Okay? These are the four areas of portocaval anastomosis. Why we need to know them? Because you need to know them because when you have a liver cirrhosis, as we said, okay, when we have a liver cirrhosis, blockage in the sinusoids, destruction in the sinusoidal structures, okay, the blood will start getting into the liver and no space to pass, so it will start accumulate where?
In the veins.
In the portal vein. وكل ما زاد الفلويد في الفين نسبة الفلويد بيزيد ايش؟ الضغط تبعه، صح؟ So they will start to form something called portal. So there will be obstruction of the blood flow. الاي cells اللي حكينا عنها دعمها بتفرز reticular fibers. They destroy the sinusoids. There is no flow of blood in the liver. Okay? فالبلد بيجي بالبورتال فين وبتجمع accumulates. As it accumulates بيرفع ايش؟ البريشر تبعه. Okay? تبع الفلويد بالبورتال فين. So that we will have something called what? Portal hypertension. ضغط البلد زاد. Okay? Once it's increased, it will start looking to what? To areas of less blood pressure. وين بده يهرب بصير من البورتوكيفال anastomosis. So the blood will start moving, okay, or streaming in an inverted direction, okay, where back into the systemic circulation. إما عبر الريكتال veins middle و inferior أو عبر الاسوفيجيال veins للأزايكس أو عبر الإيش؟ superficial epigastric vein أو اللمبر veins للIVC, okay. anterior, posterior, inferior, superior. فبيبدأ البلد بريشر يرتفع فبصير يدور. So the blood will flow from the portal to the systemic circulation. من وين بده يروح للسيستميك؟ كيف بده يهرب؟ It will run through the borders, through the portocaval anastomosis sites, the four sites. As it passes there, هاي الفينز very small بس كمية البلد هي متعودة تاخذ نصف البلد في هذيك المنطقة، صح؟ يعني هون في الامبيليكال ريجن اوكي الانر بارت اوف ابدومينال وول بيروح مع البرا امبيليكال والاوتر بارت مع السوبرفيشال ابيجاستريك. اوكي الان البرا امبيليكال مسكرات فكله الاوتر بارت والانر بارت دبل ذا اماونت will go into the superficial epigastric. فشو بصير بالفينز هنا؟ تنتفخ. They start to dilate because of blood getting more and more. Okay once the vein is dilated شو بسميها؟ varicose veins. varix okay varices بصير الدوالي بسموها. okay that's where the varices are formed. فالفاريسيز إما بصير esophageal varices الاسوفيجاس صح؟ أو بصير إيش؟ rectal varices. لما بالريكتم بسموها هيمورويدز بواسير. اوكي بس ميزوها عن الإيش؟ عن الاكسترنال وانز. اوكي ولما بصير هون عند الامبليكاس شو بسموها؟ بسموها كابوت ميدوزا. اوكي the caput medosa as you see here. ليش caput medosa? The caput means the head of medosa. Medosa, Greek monster, who looks at hair will turn into stone. صح? So the veins start to radiate from the umbilicus. شايفين كيف؟ They radiate from the umbilicus umbilicus like the rays of the sun, so they form the shape of head of medusa. Okay, that's why they call it caput medusa عند الامبليكس. لما بيصيروا بالريكتم هيمورويدز، لما بيصيروا عند الاسوفيجيال فاريسيس، وفي الباراكوليك جاترز بيبينوش كثير because of the strength of the posterior abdominal wall. The most dangerous one of these esophageal varices. ليش؟ easily ruptured, producing what? So many bleeding. فإما بيصير vomiting of blood, hematemesis أو melena. Okay? اللي هي شو بنسميها؟ from upper digestive tract. Okay? In the feces. شوفوا ليش very dangerous. Severity of blood. When you look to an esophageal varices, you will see that as they start bleeding, like you are opening the tap water. مثل اللي بتفتح الحنفية. This is a varix. Look to the amount of bleeding when there is an esophageal varix. Now, very interesting thing. What is the treatment? Clipsing. Sakura, stability. Yes. Stability. years old diabetic lady, okay, was 3 days previously, before 3 days was hospitalized, ماشي, in a different institution, مركز أولي or secondary, okay, medical institution, for her first upper GI bleeding. في bleeding من upper GI, hematemesis, okay, for hematemesis, manifesting with hematemesis and melena. What's melena? Okay. So it's not fresh in color, it's black. Okay? And upper endoscopy, okay, displays esophageal varices. Okay? The patient was discharged, okay, from the hospital without any specific therapeutic or treatment procedure because were primary or secondary institution. يعني ما عندهم capability, okay? They don't have enough facilities or material to undergo operation or endoscopic stability. So she was referred to us to evaluate this condition. The patient was continued with intermittent episodes of what? Of melena. A procedure of banding. Okay, هو نفسه stability. Okay, but instead of بدل ما بيكبس بحط band. Okay, around. Okay, of banding was planned and the was bland, ماشي, and at the endoscopy a varix with an ulcer, the ulceration, discontinuity of the stratified squamous of the esophagus, okay, there was an ulceration there, okay, an ulcer in the tip was found. This, which we call it the white nipple sign. When the varix is ulcer, يعني الepithelium is sloughed away, we would call it what? The white nipple sign, because it becomes very whitish, okay? Tip point. I will show it to you. The site of the bleeding was identified. White pole appearance, also pay attention to this. There is a white pole appearance was a characteristic finding that appeared after the ligation of the varix at the site of the bleeding. This finding, or this feature, let's say, which is the white pole appearance, okay, may be very useful in the confirmation of successful ligation of the varix. Okay? At the time of being exploring the stomach, the patient present a cuff reflex, okay, causing rebleeding of the varix. رجعت صار bleeding. Immediately, a therapeutic approach was carried out with banding to the bleeding varix. 2 rubber bands, شايفين? 2 rubber bands were placed. Okay? Now, look at here. Can you see the white nipple appearance? This indicates an ulcer at the tip of the esophageal varix. But there is no bleeding yet. Okay? There is ulcer, it's in the early stages before bleeding. This is the white nipple appearance. As they go with the endoscope now, down towards the stomach within the esophagus until they reach the gastroesophageal junction. Then they will pull back again. As they go back, because maybe of the edge of the endoscope hit the ulcer, what would happen? The bleeding starts, you see. So they went back to see what's going on. Look, there is no white nipple appearance anymore. There is bleeding, severe bleeding, you see. So the procedure is to band this or save it. He took the barracks inside the scope and band it. مش واحد حط اثنين to make sure that the ligation is very proper. Okay? How you want to know that the ligation was very successful? Look here. Look at the appearance of the tissue here. It's very whitish now. This is the white ball appearance, which would indicate that no more bleeding would happen. White becomes whitish.
Necrosis.
Just nourishment received by filtration. So very whitish ball appearance, which indicates that successful ligation. Okay? He's just going around again to check there is no more sites for bleeding. ويعطيكم ألف عافية. يوم الأحد إن شاء الله الدكتور الحيدري